Hi, my name is Maddie Stanback, and I did a review entitled Endoscopic Third Ventriculostomy as Treatment for Pediatric Hydrocephalus, a review with focus on the developing world. So, hydrocephalus is just the buildup of cerebral spinal fluid in the central nervous system, resulting in increased intracranial pressure and damage. There are two main types that we will be focusing on, communicating and non-communicating. We'll also focus on post-infectious hydrocephalus, myelomeningocele, and aqueduct stenosis. So types of treatments. The VP shunt has been considered the standard of care for many years and was developed before ETV. ETV has recently been more developed in third world countries and has shown to be effective in infants with certain types of hydrocephalus, which is previously thought to only be effective in older patients. So this was a novel idea that came out of the research we'll be focusing on. It's also been shown in combination with this choroid plexus cauterization, which we'll discuss in just a minute. This combination first appeared in literature in 2005 and came out of Uganda from a man named Dr. Benjamin Whorf. So the main considerations, there's a whole scoring system, and it boils down to age and type for choosing a treatment. So this diagram shows the enlarged ventricles that occurs with hydrocephalus. Inside these ventricles, especially the lateral ventricles, there's this choroid plexus that produces the CSF. So the choroid plexus cauterization destroys these cells. Normally, CSF flows from these lateral ventricles to the third ventricle, down this narrow channel to the fourth ventricle, and circulates this way across the brain. In non-communicating hydrocephalus, there's usually an obstruction here, such as aqueduct stenosis, which is the narrowing of this channel, that causes the buildup of CSF, enlarging these ventricles. Or there's communicating, which basically there's no reabsorption of CSF in this area. The VP shunt inserts a catheter into this region that comes out here, goes down under the skin, and drains CSF into the abdomen. ETV, however, creates a hole in the bottom of the third ventricle, which allows for CSF to escape and to flow this way across its normal route. This is especially effective for non-communicating types of hydrocephalus, as it bypasses the obstruction, but we'll see that it's been shown to be effective in more than just those types of hydrocephalus. So the incidence. Important thing to note here is that in developing countries, the incidence is much higher than that of developed countries or higher income countries. Why is that? Mostly it boils down to socioeconomic factors, such as lower access to medical care. It is also important to note that there's a higher incidence of post-infectious hydrocephalus in these third world countries. So the main findings. This hospital was developed by Dr. Benjamin Whorf with these treatments in Uganda. And he showed that ETV was shown to be 70-80% effective in infants with post-infectious hydrocephalus. Both of these groups previously were thought to only be successful with the VP shunt. This was a novel idea that it could be used in these patient groups, but mostly if the aqueduct is obstructive, resembling non-communicating hydrocephalus. However, he also combined ETV with CPC. This novel combination was shown to be more successful than ETV alone in infants, especially those with these groups of hydrocephalus. 5-year outcomes, basically no difference in survival, and even higher cognitive abilities in cases treated with ETV or ETV plus CPC with post-infectious hydrocephalus in comparison to the shunt. So why do we even want to prove that this is effective? Well, this treatment could be a better option for developing countries because it's a permanent fix and it has a much lower risk of infection, which is high in developing countries or third world countries. Whereas the VP shunt, 40% fail within 2 years and require replacement, and there's a high risk of infection because you have this foreign object in your body. Both of these pose a unique threat to populations in third world countries because oftentimes they're lost to follow-up and have low access to medical care to begin with. This shows this early failure of ETV, but after 6 months, ETV is actually favored over the shunt. Shunts usually have a later failure rate. And this group shows that those who ETV ranked highly on for the success score did significantly better than those with the shunt in those patient groups. So what's next? Basically, different areas have different needs. So third world countries are going to have different needs than the developing world. And do we have a moral consideration, a moral obligation to train more neurosurgeons and to send more neurosurgeons and to train those who are locally there to care for the world? Because as of now, there's a need. There's a high need for more neurosurgeons to be trained and for better treatment options that are more sustainable in a third world country. For more information, these videos are excellent and I highly recommend them. And thank you for your time.